So we're going to continue our talk here on the environmental and occupational diseases. We're going to spread our focus here mostly on the occupational diseases, although I suppose you could consider some of these environmental. These diseases, the pneumoconioses and the hypersensitivity pneumonitis, these are things that you tend to be exposed to on the job. So we're talking here about the pneumoconioses, coal workers' pneumoconiasis, and silicosis. Asbestosis could be lumped in here, but I talked about asbestosis in its own separate section just because it's such a big deal on the test. These three, in my opinion, are the ones that you should be the most aware of for the test. For testing purposes, you should be most aware of these because they're perhaps more common than the other ones. So with the pneumoconioses, what you tend to see here, the pattern is that these are people who are exposed to these synthetic products on the job. So I suppose coal isn't synthetic, but these tend to be synthetic products. So silica and the silica dust, and then asbestos. So these are things that typically you're exposed to in an industrial setting. The hypersensitivity pneumonitis causes tend to be more things that you see in a natural setting, like out in the fields, or so the people who tend to get exposed to this are farmers, people who work in natural settings like around trees or around certain birds or animals. And so just by its name, you know that the cause here is an allergen. And so there are lots of natural allergens that are in the environment. And so this is it's allergens that are behind this. Now, what's the common thread behind this? It's the person's job. So if a person works in a coal mine, then their history is conducive for coal workers' pneumoconiasis. If a person works around birds, then their history is conducive for birds' fancier's disease, which is a hypersensitivity pneumonitis. So the common thing here is that with these lung diseases, you want to have an occupational history because that's really going to help you with gathering the information that's necessary to really focus your questions and focus your differential on what's behind these symptoms. So look for, on the test, look for some of these jobs that are associated with these pneumoconiases and these hypersensitivity pneumonitis causes. So let's first start with the pneumoconiases. Pneumoconiases are fibrotic lung diseases. They fit the category of interstitial lung diseases, which result from the inhalation of mineral dusts, so inorganic material, commonly used in industrial settings. So getting that occupational history is going to be really important because if you know that the patient was a coal worker or you know that the patient worked construction, then that's going to help you with your differential. Characteristically, there is a latent period with pneumoconiases, so just being exposed to coal, just being exposed to asbestos 1 or 2 times isn't necessarily going to give you disorder. And even if you are exposed to it on a daily basis, you're not necessarily going to develop the disorder until later on. So usually there's about a 10 to 30 year latent period between when there is the continuous exposure and the onset of symptoms. History is going to be really important in determining the precise diagnosis, namely because getting that occupational history is going to help you focus your differential. Unfortunately, there's no cure for the pneumoconiases. It's chronic fibrotic damage, and generally, once that damage starts, it's progressive. There are ways that you can slow the damage, like stop smoking, stop your exposure, but once the damage starts to take place, it doesn't go backwards, and it usually progresses. And these patients generally will need supplemental oxygen. So here's just a list of some of the pneumoconiases. The ones in red are the ones we're going to talk about. Don't memorize all of these, but I would know these ones in the red because they tend to come up. So asbestosis we talked about in a different section. I devoted an entire talk to that because it's important. The other two are important too, but they come up a little less often. So if you're practicing in West Virginia or Pennsylvania, you'll probably see coworkers pneumoconiasis a lot. But if you practice in Minnesota or Iowa or Florida, you probably won't see it that often. Silicosis is another one. Just look at the occupations: rock mining, quarrying, sandblasting. If you know that that's an occupation that's nearby you, it's something that you're probably going to see a lot. All right. So asbestosis, I gave a whole talk to, just to recap it. I'm not going to go too in depth with it here. It is one of the pneumoconioses, which is a lung disease resulting from inhalation of a mineral dust. Asbestos was used in buildings for insulation and for fire retardation, primarily between the mid-19th century until the 1970s, when we started to discover that it was causing problems. However, there are a lot of buildings still today that have asbestos in them, and so people who work in these fields can be exposed to asbestos because the buildings were built long ago and they're getting exposed to it now. Now that corporations, public agencies have awareness of asbestos, they're able to get their employees to take precautionary measures. So we don't see it as frequently anymore. What I should say is we hope we won't see it as frequently as we did. So some of the things that asbestos is used in is spray products, floor tiles, insulating product, and then there's a cement that contains asbestos. It is, like all these things we're going to talk about today, an occupational lung disease. Primarily the people that are going to be most exposed are insulation installers, boiler makers, pipe fitters, plumbers, and janitors. And that makes sense because they work around parts of the building that are exposed. There's usually about a 20-year latency between being exposed to asbestos chronically and developing asbestosis, the symptoms. Smoking does increase the risk of asbestos-related complications, including asbestosis. So the reason behind that is because you have a ciliary clearance system in your lungs that's supposed to help you cough up the things that aren't supposed to be there. If you smoke, you're impeding your ciliary clearance system. So the idea is that more asbestos is going to get trapped in your lungs, and you're not going to be able to cough it up if you're a smoker. So smoking increases the risk of asbestos-related complications. It also increases the risk of asbestos-related cancers. So remember that the number one cancer caused by asbestosis is non-small cell lung cancer. However, the commonly associated cancer with asbestosis, which is unique to asbestosis, is mesothelioma. The most common presenting symptom is that of dyspnea and dry cough. And in any patient with asbestosis who has dyspnea or dry cough or has history of exposure to asbestos, the very first thing you should do is get a chest x-ray. So silicosis is a pneumoconiosis occurring because of chronic exposure to silicon dust, which generally is silicon dioxide. Now this is a little bit different from asbestosis in that there is a simple silicosis and a complicated silicosis. So it really depends on how much you're exposed to it and for how long and the quantities. So in simple silicosis, the patient may be asymptomatic and they may only show findings on a chest x-ray, and it's just incidental. But they may not have any symptoms at all, maybe a dry cough. In complicated silicosis, however, the characteristics of infiltrative lung diseases are quite prominent. You'll hear rhonchi and rales and wheezing on auscultation. And a lot of these patients will have tachypnea and will complain of shortness of breath. In advanced cases, because this causes a fibrosis change of the lungs, it does result in pulmonary hypertension, and that can lead to right heart failure. So you can start to see those signs of elevated jugular venous distension. You can see edema in the lower extremities, a enlarged heart silhouette on chest x-ray, and so forth. The best initial diagnostic test is going to be a chest x-ray. That'll give you some of the characteristic findings of silicosis, if indeed it's present. And the chest x-ray is used to differentiate simple from complicated silicosis. So when you get that chest x-ray, what you're going to do is you're going to look for nodules. And primarily in silicosis, the nodules are going to be in the upper lung zones. The small nodules are less than 1 centimeter, and the quote-unquote large or coalesced nodules are greater than 1 centimeter. So usually the small nodules are quite small. They're usually about 2 or 3 millimeters in diameter, and you'll see quite a few of them. But those small nodules do not cause symptoms that frequently. What you get into where the problem comes is when those nodules start to coalesce. That takes up more mass in your lungs. So in simple silicosis, you see multiple small nodules. They can be scattered diffusely, and they tend to be in the upper lung zones. With complicated silicosis, those nodules become so frequent they start to coalesce, and so you see these what appear to be masses, and they're greater than 1 centimeter. You can also see hilar calcifications, which is characteristic of silicosis, but the lack of hilar calcifications does not rule out silicosis. When you get hilar calcifications in silicosis, they tend to look like eggshells, so they call it eggshell calcifications. And then you can also get overinflation of the lungs. So for treating patients with silicosis, all patients who are diagnosed with silicosis on chest x-ray need to get a TB test. Why? I don't know. There just happens to be this correlation between silicosis and TB. So the recommendation is that once you've diagnosed a patient with silicosis, the very next best step is to get a TB test. So what you're doing for the TB test is you're getting the skin test, the Mantoux test. So you're injecting tuberculin into the skin, and you're looking to see if you get a reaction. If there's an induration of less than 10 millimeters, nothing needs to be done. The patient's negative for TB. If the induration is greater than 10 millimeters, so we're just doing this TB test here, then you need to get a sputum sample as you normally would in these patients. Now, this is a little different than how it normally works for a TB test. Normally for TB, if you have a positive Mantoux test, then you're going to get a chest x-ray. But we can't do that with silicosis because we don't know where we can't tell on a chest x-ray what a silicosis lesion is from what a tuberculosis lesion is. So we have to go right ahead and get a chest x-ray. So if the Mantoux test is positive but the sputum sample is negative, we're going to make the presumptive diagnosis of latent TB. So they have a positive Mantoux, meaning they probably have TB, but the sputum sample is negative, meaning it's not active TB, it's probably latent TB. And so we're going to treat them on isoniazid for 9 months. If the sputum sample, however, is positive for TB, then we treat them as if we would be treating them for active TB, and we put them on a multi-drug therapy. And those drugs include rifampin, pyrazinamide, isoniazid, and ethambutol. Any patient with chronic lung disease should be getting their lung vaccinations. So those include the 23-valent pneumococcal vaccine and the annual influenza vaccine. Of course, smoking cessation is always helpful in any chronic lung disease, and avoiding further exposure is useful as well. Coal workers' pneumoconiosis is very frequent among coal workers, but unless you practice in an area where there are a lot of coal workers, you'll probably never see this. So most patients who have coal workers' pneumoconiosis, even if you were to be able to diagnose this on biopsy, which is the most accurate test, most of them would be asymptomatic. However, 10 to 15% of all coal workers have coal workers' pneumoconiosis, and a lot of them are symptomatic to one degree or another. Again, like in silicosis, we divide this up into simple coal workers' pneumoconiosis and complicated coal workers' pneumoconiosis. And any complicated pneumoconiosis can also be called progressive massive fibrosis. And that makes sense because what you're getting is you're getting these scars in your lungs which are starting to join and coalesce, and so you're getting massive fibrosis. The symptoms for CWP are very similar to silicosis. So in simple CWP, you can have asymptomatic, or you could just have a cough. With complicated CWP, you can have cough, dyspnea, shortness of breath, rales, rhonchi on auscultation, and you could even have right heart failure. So really the same symptoms you have in silicosis, the only difference is that the history is different. In a patient with coworkers pneumoconiasis, they're a coworker. So the diagnosis, again, here is going to be a chest x-ray. That's the best first step in diagnosis. The chest x-ray is going to help you differentiate simple from complicated disease. Certainly, you can have a patient with simple CWP who has cough, dyspnea, and shortness of breath. So we need to get that chest x-ray to assess the extent of their disease. So once you get that chest x-ray, again, you're pretty much using the same criteria you use for silicosis. Multiple small nodules, primarily in the upper airfields, would be simple, and complicated would be coalescing nodules, greater than 1 centimeter. So let's look at some, also treatment. So treatment for coworkers pneumoconiasis, you're going to immunize them, both the annual flu vaccine, 23-valent pneumococcal vaccine. Stopping smoking is useful, and then minimizing exposure. Most patients who are coworkers are not going to quit. That is part of the culture out there, and most patients who are coworkers have been doing it since they were kids, and that's all they know how to do. So it's going to be really hard to get them to quit. What they can do is move to areas within the coal mines that have lesser grades of coal. So that's something that can be done, and the Americans with Disabilities Act would protect them for that. You should consider a TB test, particularly if the patient has had weight loss or low-grade fever. However, it is not mandatory like it is in silicosis. I don't know why that is. Okay, so this is silicosis. You can see here you've got these nodules. These are a little less than 1 centimeter. So I would say this is right on the border, and you also get this. You also have these. You have these calcifications here, and then you got a little bit of fibrosis out here. But I would say that this is probably verging on the complicated silicosis. So even if you look at the heart is also it's right on the upper limit of normal for size. So here's those eggshell calcifications coming off the hilar lymph node. I don't think you can really see it on here, but you can definitely see it on this one. So these are hilar calcifications. And also you can see what appear to be some nodules. Here's some more silicosis. This is definitely complicated silicosis. So we have coalescing nodules, which are seen in these opacities here. So here, definitely here, here. So here's some more. So we can't really tell how big this heart is because of, well, it looks like you got some stomach or colon right there, and then it's kind of hard to tell the exact size of the heart, but no matter. Here's your coalesced nodules on both sides. Okay. So here's coworkers pneumoconiasis. Really, it's going to be about the same sort of thing. You've got some opacities throughout the lung representing minor fibrosis. But what you're really looking at are these opacities, and they tend to be in the upper lung fields and around the hilar lymph nodes and proximal trachea. So here's some more. This is probably simple CWP, maybe verging on complicated. And this is definitely complicated CWP. So you got your coalescing nodules here. And of course, it's always going to be important to have your history and your symptoms. I mean, I wouldn't expect anyone, and the USMLE is not going to expect anyone to say, okay, look at this chest x-ray, what is it? So just remember, with these nodules and this history, that's what you're looking at. Now, it's going to be important to have chest x-rays of these people every 6 months to a year, particularly if you have new symptoms coming up. Why? Because you want to be able to see if there's any new lesions coming up, because that can represent cancer. So how about this? What's this? And if you watched my other video, you'll probably know what this is. You don't even need to look for the lesions, because there's a dead giveaway on the bottom, right here. This is asbestosis. And so these here are diaphragmatic calcifications. You've got sort of a shaggy heart border, and the heart is a little bit on the big end. So you got cardiomegaly. This is advanced asbestosis. Okay, hypersensitivity pneumonitis. So we're talking about something totally different here. This is not pneumoconiosis. This is different. Now, this is something you can be exposed to on the job. However, this is a totally different entity. So hypersensitivity pneumonitis is an inflammation of the lung parenchyma due to inhaled exposure of organic material. With the pneumoconioses, we're talking about inorganic dusts. Now we're talking about organic material. So things that are made by fungus, or even perhaps different fungi, or things that are made by bacteria. These are organic life material. So these can be dander, grain products, wood bark, fungal antigens, and so forth. And what you get here is not an immune reaction to a foreign, well, it is an immune reaction to a foreign protein, but what you're getting here is not just direct injury. What you're getting is an immunologic reaction to an invader. So it's as if a bacteria or a fungus is coming into your lung, but it's attacking it from the outside. So there are different occupational predilections for hypersensitivity pneumonitis. Some of the most common that come up on the USMLE are farmer's lung, which is exposure to moldy hay, and it affects as many as 540 out of 100,000 of those at risk. Primarily, these are people who work with hay, namely farmers. And then bird fancier's lung, which these are people who work with birds. So you can get it from bird serum or bird excrement. And this actually affects as many as 1 in 5 pigeon breeders. And I don't know if that necessarily extends to people who care for other birds, but it is quite frequent in pigeon breeders, as far as the literature says. So that's about 20%. Now, there's variable manifestations of hypersensitivity pneumonitis. You can have acute, subacute, and chronic. What I would remember is the acute and the chronic, and then remember that subacute is kind of in between. So acute is when you have sudden extreme exposure. So short-term heavy exposure. And what you get are constitutional symptoms, fever, weight loss, night sweats, and you get the respiratory symptoms, productive cough, dyspnea, tachycardia, tachypnea. And this has a much more dramatic appearance than your chronic disease. So, for instance, if you went for a 1-week pigeon breeding camp and you were exposed to birds suddenly, then you may develop acute hypersensitivity pneumonitis because you would suddenly be exposed to it, and your body is attacking, the immune system is attacking a foreign substance, and that immune reaction is going to be very strong. Whereas in chronic exposure, the immune reaction is going to be a little bit held back since your immune system is more used to it. So that's probably the best way to think about it. So anytime you get the first infection with anything, that's always the worst infection. The second, third, fourth infection is not as bad, but it does do long-term damage. So acute manifestations are usually the way somebody reacts the first time they're exposed to these pathogens, and then as they go on, they'll develop the chronic symptoms. So the chronic symptoms just have to do with chronic inflammation of the lungs. So this is pneumonitis, pneumo meaning lung, itis meaning inflammation, and the inflammation is due to the immunologic reaction of to these antigens, the moldy hay, bird serum and excrement, and so forth. So the patients you see the acute exposure in are people who haven't been doing this very long. People you see the chronic exposure in are maybe the guy who's 62 years old and he's been a farmer all his life, or the woman who's 50 years old and she's been working around birds since she was a teenager. With long-term exposure, like I said, chronic disease, you're going to have your typical fibrotic lung changes. You'll have cough, non-productive cough, dyspnea, possibly even clubbing, and right heart failure symptoms. The therapy for hypersensitivity pneumonitis is avoidance. So usually it's easy to tell what the problem is based on the patient's occupation. So the patient will want to avoid those things because they do have an allergic reaction to it. And then oral corticosteroids can reduce the inflammation to a certain degree. With chronic, it's generally a pretty bad prognosis because the damage has been done. With acute, the prognosis is better because it's the first reaction, and so most of that inflammation is going to drain away. With chronic, you've got some long-term changes to the lung tissue. Now, I will say that not everybody who is a farmer, not everybody who is a pigeon breeder is going to develop this, because not everybody is allergic to this stuff. This is just like being allergic to pollen in the air where you get your seasonal allergies. Some people are allergic to it, other people aren't. So it's important to keep in mind. You could have somebody who has farmer's lung who would be just fine with pigeons and vice versa. So it's something that just certain people are predilected to. But all you really need to know is the difference between acute and chronic, which is based on frequency and intensity of exposure, and that the therapy is avoidance and oral corticosteroids. And the corticosteroids are more effective with acute. Chronic has a worse prognosis. So here are some of the other occupations, and this is not comprehensive. I got this from the CMDT 2010, and you can see there are lots of different occupations where you can be exposed to these different antigens. So most of them are bacterial or fungal, and the sources range from humidifiers and heaters to air conditioners to wood to hay to bird excrement. So there are lots of different things. The differential diagnosis for hypersensitivity pneumonitis are going to include the various pneumoconioses. So that would make sense just based on the fact that it's a patient with lung diseases with an occupational exposure. The difference is the occupational history. So if it's a coal worker or if it's a construction worker, they're more likely to have a pneumoconiosis. If they're a farmer or a bird trainer, they're more likely to have hypersensitivity pneumonitis. Secondly, the pneumoconioses never present acutely, or very rarely present acutely. Hypersensitivity pneumonitis quite frequently presents acutely, and it also quite frequently has a lot of constitutional symptoms like fever and weight loss. Community-acquired pneumonia is another thing to think of, especially if you have an acute hypersensitivity pneumonitis. So the chest x-ray is going to be helpful there, even a sputum sample, and if the patient has a questionable exposure history. Various collagen vascular diseases, and then Goodpasture syndrome. And that's particularly if the patient has hemoptysis. Hemoptysis should never present in the pneumoconiasis or hypersensitivity pneumonitis. Generally, there's no vascular damage. Now, of course, it can get that bad, but it generally doesn't. So if you have hemoptysis, you should be thinking of things like Goodpasture syndrome or something else rather than the pneumoconiasis and hypersensitivity pneumonitis. So for diagnosis, the occupational history is going to be central. The best initial step is a chest x-ray, which is going to help you differentiate pneumonia, particularly if the patient has acute symptoms and they have fever and weight loss. And usually with pneumonia, you're going to have a lobar consolidation, whereas in hypersensitivity pneumonitis, you'll see a general inflammation. Now, you can see general inflammation in walking pneumonia, but again, it's going to be based on the patient's history and the patient's occupation.
So, I mean, just by x-ray, you can't necessarily differentiate everything. You got to go a little bit on your history. Patients who have hemoptysis should have their anti-GBM levels drawn for possible Goodpasture syndrome, particularly if their routine labs are abnormal. And by routine labs, I mean their kidney labs. Other tests may be useful based on suspicions for collagen vascular diseases. You always have to include collagen vascular diseases in any restrictive lung disease or in any interstitial lung disease. Treatment is going to be oral prednisone. That's the cornerstone for therapy. And in chronic cases, generally they're going to need supplemental oxygen because they have the fibrotic changes of their lungs. They're not going to be able to diffuse oxygen as efficiently from their alveolus into their circulation. And the supplemental oxygen will improve quality of life, but it does not increase survival.